Hello, my name is Jim Keller. I'm a professor of pharmacy medicine and oncology out of the University of Texas at Austin and the Health Science Center in San Antonio. Today we're going to talk about the Neurokinin-1 receptor antagonist, the NK1 receptor antagonist, in chemotherapy-induced nausea and vomiting, also referred to as CINV. From a mechanism of action, the NK1 antagonists typically work centrally. They work at the brainstem, the chemotherapy receptor trigger zone, and they work through blocking feeds through the vagus nerve. When you look at this next slide here, we'll show you a listing of the current agents. We go from aprepitant, oral form, to the injectable form, Fosaprepitant, to netupitant, to Rolapitant. These are the 4 available NK1 antagonists. You can see from the slide here, this is basically a class of agents. There are some small differences in some of the specifics, but they all have their activity in delayed nausea and vomiting. This next slide here deals with the activity of aprepitant and Fosaprepitant. On the left slide, you can see here that basically the IV form versus the oral form are basically equivalent. So IV equals PO. The right side of the slide here shows the difference between a 3-drug regimen, including an NK1, in this case being Fosaprepitant, versus a 2-drug combination of a 5-HT3 antagonist and dexamethasone. You can see here that in modern metagenic chemotherapy, the 3-drug combination does better than the 2-drug combination in at least 2 of the 3 studies. In the delayed phase, again, if you look on the right here, you can see there's basically no major difference in highly metagenic patients. And on the left, you can see that, again, by adding the third agent, the NK1 versus 2 drugs, that patients on 3 drugs do better than 2 drugs. This next slide, again, shows you a complete response from another NK1, NEPA, which is netupitant. And this again shows, if you look at the various studies done on the left here, that again, where you use the 3 drugs versus 2 drugs, the 3 drugs does better than 2 drugs for overall complete response. And again, you can see on the right slide, once you have a better response, that response is maintained over multiple cycles of therapy. Finally, to Rolapitant, our last NK1 that was just approved. Again, in this study, it shows, again, if you look at the 3 drugs versus 2 drugs in the 2 trials that have been reported both in moderate to metagenic chemotherapy and highly metagenic chemotherapy, patients on the 3-drug regimen do better than 2. And again, on the right slide, because these patients do better in the very first cycle, that improvement is seen through multiple cycles of time. So where are we with the safety of these NK1 receptor antagonists? Generally, these are well-tolerated agents. Most of the reported toxicities, fatigue, diarrhea, some dyspepsia, little hiccups. Fosaprepitant does have some infusion site pain, some irritation. It's been reported to be less than 1%. For NEPA, again, it's pretty much consistent with the others. But again, remember, this also includes palonosetron, so there don't seem to be any significant difference in toxicities. And the one thing to remember for at least some of the NK1 receptor antagonists, there are problems with drug interactions because it is a drug that's metabolized through the P450 enzyme system. So drugs that also can go through this enzymatic system, such as dexamethasone, you must be modifying the dose. In summary, the NK1 receptor antagonist inhibits substance P, which is associated with nausea and vomiting, more specifically delayed nausea and vomiting. Unlike the 5-HT3 antagonists, NK1 receptors have their primary activity centrally, and as I said, their main effect on nausea and vomiting is in the delayed phase. When you look at any of these drugs that are added to a 3-drug combination, the NK1, 5-HT3, and steroid, they all seem to do better than a 2-drug combination, and that's both in MEK and HEK. And these agents are generally well tolerated, and again, in addition, they don't appear to have any significant cardiovascular effects. With this, I'd like to stop and thank you for your attention.